So we know that migraine is affecting a lot of patients. We know that the number of patients worldwide, there's a great disability to patients in terms of pain population. In pain management, we quite often don't just handle the simple cases. Quite often, by the time they come to us, they're depressed, they're anxious, they have lost work, and they have a lot of problems or psychosocial issue. So there's a lot of comorbidities when the patients do present to us. And some of the patients actually have been sitting on it. They have been taking a lot of painkillers. So it becomes a medication overuse headache. So the condition can be quite complicated, from a episodic migraine to chronic daily headaches to eventually becoming a very major impact to the patients. And we know from different literature, from science, from neurology literature to pain literature, to even neurosurgical literature, the current understanding of migraine is actually quite complicated, more than just the usual depolarization of the cerebral membrane. And quite often it's not just blood vessels, it's not autonomic nervous system, but a complex of trigeminal cervical nucleus problem. And there are often a lot of structures that patients may present with, and sometimes they present with cases that has been diagnosed with migraine, but it turns out that the patient has got some other things in the trigeminal ganglion as well. Sometimes they have cluster headaches combined with migraine. Do we have complicated transformation of one form of headache to another form of headache? So quite often we call upon each other. My neurologist friend who are interested or board certified in headache specialty, and us doing pain specialty, we actually call each other. I mean, we combine our expertise and we put them together and we come out with a treatment plan for the patients. So the hypothesized sequence of events of migraine is really something that is more than just what you and I can see. Quite often the triggers can be poorly understood. The cortical waves of the spreading depression is what a lot of neurologists have been pushing for and presenting with aura. And certainly there's a lot of brainstem activation as well. So the trigeminal nucleus becomes a target for management. So it's the brain area. So it's the other types of comorbidity areas as well. Certainly we want to also address not just the symptom, but also going back to the roots of the problem. And recent development of a few new drugs have been very exciting. And I'll share a little bit of what we have gathered from a different literature that has been fast evolving. We also have seen cluster headaches. And again, the literature for the combination of different types of headache that comes together is quite interesting, because we thought that it's probably a progression of a central nervous system hypersensitivity, and it's cervical trigeminal as well, as much as it's hypothalamus. So while it's distinct in the International Headache Society, American Headache Society definition, but quite often when we look across the overview from different literature, and if you look at all the clusters of different consensus of treatment, whether it's in terms of neurologists or whether it's interventional pain specialists, or whether it's different kind of anesthesiology angle, the complex of the cervical trigeminal nucleus is more than just what we have been understanding. Quite often we see, for example, the CGRP here on number 2, that is actually showing here, is actually one of the main targets recently, but you can see that there are so many more targets that we can certainly be looking at as well. The difference between different types of neuralgias, the different types of headaches and facial pain and maxillofacial kind of conditions continue to be a complex. I find that it's very important and it's interesting that while some of the cases can be very classical episodic migraine, very classical medication overuse headache, some can be very classical cluster headache, but we have many patients that really is a mixed bag of both, a mixed bag of 2 or mixed bag of 3. And quite often when we talk to our neurologist friends, some of them will be, oh, I think I believe in this diagnosis more than the other diagnosis. So I think that the current understanding of it is really having one accurate diagnosis as the primary diagnosis, and then followed by probably a secondary diagnosis will be useful, because you may have to use multimodal, multidisciplinary, multiple angles before the patient can really get that relief, avoid the admission to hospitals, and avoid multiple medications. And certainly what we want to do is to relieve the pain and suffering at the end of the day. And we want the patient not to need to be admitted to hospitals again and again, which is really currently the main problem. If you look at just differentiating between, say, migraine and tension headache, and quite often we go on the International Headache Society classification. We certainly look at all the types of the criteria, and certainly this can be quite distinct. All right, these two headache is really quite distinct and it's quite easy to differentiate. But quite often the patients may present with something else that may have aura that's also quite distinct. Then you can see the speech difficulty, hemisensory disturbance, visual disturbance, and occasionally without the headache as well. They can come with aura without a headache. And the focal neurological deficit lasting 1 hour or less before the headache actually happens. But there are cases that also come with headache and danger signs. And that's a very, very something that we always cannot forget. Recent onset unremitting, fever, focal neurological deficit, seizures. These are all the basics that we really cannot forget. Whether we are pain specialists, a neurologist, a family physician, or rehab medicine, or anyone else that deals with patients who come in with neck or head pain that suddenly woke up with suddenly headache. These are all something that we have to be very careful and cognizant. Or nocturnal headache, nighttime pain, and it's worse, especially in the morning with nausea, vomiting. Or loss of cognitive behavioral kind of personality change. That also must be something that we take it seriously. Of course, physical examination becomes the key. Bruxism signs can be a very interesting sign. Some of them present with migraine and temporal mandibular joint disorder, and the TMD problem actually sets off the migraine. As we know, there's often a trigger, and sometimes it's the temporal mandibular joint disorder that sets off the migraine as well. And if you picked up all these things rather than just picked up the migraine, you certainly can obviously help to go back to the very root of the trigger, and you can obviously then solve the problems. Certainly, one of the main problems besides the danger signs is also to rule out also the patient's background or personality. If the patient has been having insomnia, patient has been anxious, and certainly if you will also move on to actually address those issues, then the practical management is really managing the patient, not just, oh, the patient has migraine, but what about migraine and something else? And I think this something else could really be the source of the problem, the cause of the problem, or even the outcome of the migraine. And certainly if you would manage both, you certainly can reach out to really a very reasonable, rational polypharmacy, but necessarily on certain targets and certainly one molecule on certain things is an angle to look at. And polypharmacy amongst migraine sufferers may be attributed to the limitations of current therapies. We don't have one drug that helps to solve the patient's condition and comorbidity, condition and triggers, condition and predisposing factors. We certainly have to be careful and rationalize it. So the evaluation of the medications taken over a long period of time, on average, is about three to four tablets, different types of medicines taken just for headache alone. And if you do, the daily types of medications is taken up about 41% of patients can be more than 5. So that's quite a significant numbers. Current therapies for acute migraine have the tolerability problems, the need for rescue medication problems, or medication overuse problem. And certainly, we are also concerned whether there's cardiovascular diseases, whether there's any other ischemic kind of conditions, whether we want to be careful. For example, NSAIDs, COX-SIPs is one of the classical reasons to be concerned about. And we want to really be careful. This decision to initiate preventive therapy then becomes also the other concern, right? So when do we start preventive medicine? Rather than just depending on the frequency, or depends on the impact, or depends on the response to prior acute treatment. What about patient's preference? All right, sometimes we have to think about the patient as the person who make the decision as well, because end of the day, they are the ones who are feeling the impact and they're feeling the difficulty. Should be considered for preventive if they are in any of these possibility. But the American Headache Society goes as far as if the patient has a preference for it, we certainly want to be a factor to consider that as well. So the goal for migraine prevention is not just to reduce the frequency, but the intensity, but certainly more important is to reduce the overuse of acute medications, and which may lead to then MOH. Okay, so one have to be very mindful of this, and definitely look at starting a preventive therapy as early as we think we have reached such criteria. And if its cost is concerned, obviously we have to think about it as well. The delayed efficacy of the drugs, whether it's poor tolerability of the drugs, for the preventive medicines, we also have to be thinking about. Sometimes when you look at the literature, it's about 50-something% of them has some benefit. So you will have another big gap of about 40-something% of patients not able to benefit from it. So high discontinuation rates for some of the preventive options, especially the older versions, whether it's beta blockers, whether it's the Topamax version, has been subjected to studies, right? Many studies now, some studies have now shown that the CGRP receptors inhibitors would be more superior to even the Topamax option, topiramate option, and that has been shown. And patient preference as well, whether patient want to be taken injections, then they don't have to have taken too much tablets on a daily basis. It's something to consider, right? So we all know about some of the very old acute medicine options, and this is still be widely practiced and widely used in the family physician setup, and it's important not to underestimate. Simple medicines may be all that is necessary sometimes if it's just episodic, infrequent kind of migraine headaches. But certainly one has to be careful once it's more than 2 times a week and it's more than a month or 2 months. We certainly want to be careful of medication overuse headaches. And certainly whether it's triptans, NSAIDs, COX-10s, we want to make sure that we minimize it and think about preventive option prophylactically. If it's something more than 4 times a month frequency, or total headache days more than 7 times, and also when it's perimenstrual, because that's be monthly, every month, a quality of life issue, something to think about, whether you want to take the acute treatment just preemptively or you want to use preventive options altogether. And certainly a quality of life issue would certainly be discussed openly with the patient. Okay, so the old class of prophylactic option has also been listed down, from beta blockers to classic amitriptyline. I personally prefer nortriptyline, and certainly SNRIs, if you have a mixture of a bit of a mood disorder as well, will certainly be useful. Certainly verapamil has been pushed up last time, and there's a lot of problems with the bowel issues. And certainly one has to be thinking also of Botox now, but Botox has been a very old drug now because it's been widely used and it's been very effective for some, but we've also found a lot of failures with them. So what about combination option would also be explored in some of the cases where it's getting quite complex. So, and this Botox studies has been well shown. I don't want to revisit it too much. It's an old kind of option that is well used, all right? 155 units over 33 points, but some of the bookshops that we've gone to, we have actually found that it's necessary to 180 units. I think this is an option for certainly some of the groups of patients, and to consider this much. Now, I'm just want to zoom in on some of the new drugs because this has been the area of interest recent times, whether it's the CGRP inhibitors on the receptors or on the ligands, have all been pushed up forward. And certainly CGRP is just one of the receptors that is effective, and I've shown you that algorithm on the functional pathophysiology. And certainly monoclonal antibody now is the way to go. Least side effects because they are really monoclonal. They're just single ligand or single receptor, and it's pretty effective for some of them as a preventive option. And it becomes quite widely well accepted by patients, even though costly for some of them. But there are now increasingly more and more less costly options coming out as the competition really hits up in this region, in this area. The latest, besides the previous Iranimab, which is the first Imovig or otherwise, has now been subsequently been surpassed, or some of them have been competed against quite actively by the other classes of drugs like fremanezumab and calcanezumab and itinezumab. And certainly orally, Pfizer has necessarily come in the foray with Nurtec, which is the Japan, which is something that is very interesting. The Diptan is coming up, but we don't see the Diptan yet, but we certainly got the Japan now, which is the Rimigepan, and we started to use the patients for this, and it's quite interestingly abortive and preventive at the same time. Up to a year of study has been done. It's very, very interesting. So that's oral, and some patients actually prefer this because it's very fast. This is probably one of the fastest that we've seen because within 2 hours is what they've studied, and we have also seen it's pretty fast. IV VART is also pretty fast with some of them to be quite good and useful as well. So, but it's just a little bit more in terms of intravenous options. So there are many molecules that is in the same area that is coming out all at the same time. And so certainly you want to see them as a comparison across the board like that. But really, when it comes to efficacy, I've tried all of them. I've tried whenever they appear. We certainly want to say, okay, you've tried this, it doesn't seem to work. This is on the receptor, maybe you work on the ligands. and maybe you work on a monthly, which is the current Emgality option, which is useful for monthly. But then after that, the patient will say, what about 3 monthly? So 3 monthly, then we will use things like Ajovy, which is useful. And certainly many studies have now been shown in terms of the real world studies have shown up to as long as 24 months for most of the studies, showing that they're very effective. So it's really about which is your patient's preference, and in terms of cost as well, because the latest drug that we have currently, which is the Japan, which is the Remijapan, we're trying to find out whether it's really cost effective. We're still trying to weigh out whether it's the patient is really going to find out more effective and yet definitely less costly in terms of long term. So those are the things that we have been still learning for ourselves. And when we share our kind of story with different colleagues in terms of the use of this acute and at the same time within the same molecule, a preventive one, it becomes quite interestingly acceptable for patients as well. So you don't need to take, for example, NSAIDs on top of this, for example, for a start. You can actually just zoom in and do this Nurtec. And it's orally dispersible, disintegrating tablet. So it's very fast. It's just dissolved into the sublingual or the oral. It's very fast, and it just gets effective quite fast. 75 milligrams alternate day, every other day. So this is something that has recently just come about, and it aborts the headache, and at the same time, it also helps in the preventive option. So it does reduce the medication overuse kind of angle. So we're trying to look at that as a next class of action that is very effective. Certainly, we want to usefully look at the cognitive part, the insomnia part, all the rest of the triggers, and whether the patient has got problems with TMJ, TMD problems. So like the DTANs, we still don't have, but the Japans have been out in this current setting. And you can see that increasingly the older class of drugs are now being spaced out and phased out over time. But certainly some of them are still ongoing. Now, but still, it does still leave a gap, all right? Now, even with all these latest options that we have, as the title says, practical management means, does the patient solve its problem, and is that necessarily requiring lessen the need to come into hospital? So we have got cases where we have to use interventional pain as an option. So some of my colleagues, neurologists, neurosurgeon, would then involve me quite often halfway through with these treatments or subsequently, and they found that it doesn't seem to solve the problems. They've tried all the drugs. That's when we really actively come in as well. Then these are what we call the difficult headaches, all right? The difficult headaches is when you either have a daily headache that doesn't seem to solve the problem, the patients continue to find it significant and has to be admitted, or in some cases, pregnancy. And some of these classes of drugs can be used very carefully, but one has to be very balanced and try to explain to patients no drugs are proven safe during pregnancy, but some are a little bit known over time. So managing all the rest of the comorbidities is very, very crucial, and certainly want to look at it as well. So the interventional approach as the last part of it sometimes come really right in the middle. We don't want to wait for it to be too late, because by the time patients get too depressed, too many drugs, including the psychiatric drugs, it becomes very tough to actually break through. So for interventional pain, we actually target also the different autonomic nervous system, also the trigeminal ganglion, and in some cases, again, off-label sometimes, we actually assess the patient. For example, this patient actually has atypical facial pain as well as dental neuralgia. He's been diagnosed with migraine at one point in time, given a lot of migraine medication, but in the end, the patients actually had a very severe atypical facial pain as well as neuralgia after we have done what we call a consensus discussion, and then eventually subject her to some interventional treatment over the stellate ganglion as well as the trigeminal, block it a few times, then revisit the preventive treatment options, and then they start to work. So sometimes we really need to reset the nerve, so we need to really calm the nerve down and break through with this kind of interventional option. The gastrin ganglion has been traditionally done for trigeminal neuralgia, but increasingly we find that besides the cervical region, which is the trigeminal, this is here, and the cervical C2 is really a target for reducing the barrages of signals coming through to create this ongoing episodic or chronic daily attacks of all these neuralgias. And so it becomes something that is useful, whether it's cervicogenic headache, whether it's the migrainous, whether it's the very severe clusters where we target sphenopalatine. So these are the kind of targets that has been scientifically studied in terms of randomized control trials, in terms of case studies, have all been shown. So sometimes, while we may not have a fantastic, huge numbers to prove that they are definitely indicated, but at the back end of the options, when patients are really breaking through, and it's not really going far, one has to give them these options. I've got patients that I'll show you in a while that really had been through a lot of trouble and problems with their headache before they finally get some respite and cut down their admission rate. Third occipital nerve also is one of the differentials that we want to target. The facet joint is also one of the major targets because this can trigger off a lot of signals. So these are not the cause of, this is not a standalone, the only problem, but the patient can start with cervicogenic headache and then develop into a migraine. Okay, migraine after all is a clinical criteria diagnosis, but this is more anatomical. So there are some cases where the anatomical problems then lead on to the migraine itself. So it's not a predominantly classical migraine, but there are cases where there are other sources of pain that trigger off the migraine. Okay, so these are the cases where we have to subject them to diagnostic block, and we actually put some contrast through, and if it's confirmed it works for them, and then after that, it really reduces pain, we actually desensitize it, radiofrequency it, that lasts for 2 years or 3 years, break the cycle of the pain. So I'm trying to share with you, there's some of these cases that we diagnose just migraine, but we didn't really further differentiate if there's a secondary diagnosis, if there's another trigger, that you can actually stop the barrage of signals going into the cervical trigeminal area. TMD is one of the major ones. They grind, they clench, then you see the buccal mucosal really sinking in with the denting, and you see the tongue denting down, and it's classical. And if you don't solve this problem, you can do all you want with your migraine treatment, it just doesn't solve the problems. Okay, of course, psychotherapy or even physical therapy is important. We subject them to group therapy, get good therapists on board, we work them together, and then put them, even acupuncture, we have done it, okay? Together we acupuncture some of them. Now, this particular patient is one such patient. She's been through about 5 different neurologists. 2 of them are headache specialists, and also 2 neurosurgeons. Admission rate was almost every 2 weeks or every 1 month. By the time she comes to me, I saw her as a very frail lady. Otherwise, there's fantastic personality, but she has been admitted so repeatedly, she's very depressed. So eventually, after all the barrages of treatments options, after 1 year of repeated admissions, she's almost depleted her very high-end insurance company coverage. We decided that she needs to have an option. So this is off-label, but this is an option. And she actually found tremendous benefit with a trial of spinal cord stimulator. So this leads actually sits right all the way to C2, C1, and we can actually send signals down to the cervical trigeminal nucleus, which is actually sitting right at the C2 junction there, and they can actually feel a lot of signals coming up, and they actually find it a lot better. And we actually do what we call a crossover trial on her. That means we turn it on to a high frequency, paresthesia-free. She cannot even feel any signals. And sometimes we turn it down, sometimes we turn it up. And when we do all that, we prove that it actually works for her. All right, so crossover confirmed. We actually put an implant into her. Today, she's about 4 years after the implant. Her medication use now is now almost PRN when necessary, once every 4 to 6 months. Her admission rate is only once every 2 years. Sometimes you need it not just for the purpose of doing intervention, she just needs the insurance to recognize that she needs to be ongoing coverage with some medications. She's hardly on any medications for painkillers. She's actually on just some preventive options. I think she's on IV Vyepti, and other than that, she's not on any painkillers. And she's bubbly, she's traveling, she's finally out of hospitals for the last 4 years. So this is something to consider about for the practical management. Thank you very much for your attention. Thank you.